Hi, sir. Are we ready?
Hello.
Hello.
Yeah, hi. Rajesh here. Hi.
Hi, sir.
Is it Pratik?
Yes, sir.
Oh, hi.
So we'll be starting in 5 minutes, sir.
Okay. That's fine. Is Amit already online?
I think he will join
Oh,
us.
yeah.
Yeah.
He's there. He's there.
Yeah.
That's fine. That's fine. Okay.
Hi, Sham. Khushbu this side.
Oh, hi.
Professor, hi.
Hi, hi.
Karthik.
Oh, Professor. Morning.
So Amit, sir, will start at 5:30 sharp.
Yeah, I think we can start.
Yeah. So 4 minutes we have got.
Yeah.
We'll just wait for 4 minutes and then we will start.
Okay.
So I'll just introduce and I'll give the outline and then I leave it for Amit to moderate
sir.
and we'll go for the
So I'll just start with the introduction of the session and I'll introduce you and then you can introduce Amit, sir, and then we'll start with the session.
Okay.
So we are trying out a few things. We are trying a YouTube live also on this so that we can then later on have these for our records and also maybe put it on the Sarcoma Education Foundation channel.
Okay.
So for people who are not able to access it today, they can then go to the YouTube channel and then access it through there.
Yeah. It's a good initiative, I think.
Just that actually we also have another conference running today, OrthoOncoCon. So there's a slight overlap, but since this was radiology oriented, we thought we'll just go ahead with it because the target audience is slightly different in this.
Yeah.
Amit Chaudhary sir, आप क्विज के लिए ready?
Bilkul.
Sir, we have finished through the login process and ready to run the quiz when we get a chance, right?
Okay, but you will have to make me a host during the quiz for projecting my screen.
Yeah. So you can coordinate with Nikita and sort that out.
Okay, sure.
Yeah. Nikita, you can just help Amit sir.
Sure, sir. I will help him.
Yeah, it's done, sir. Yeah, Amit sir, you are now co-host. You can share the screen.
Okay. So
So Rajesh sir, this is for the quiz at the end of the session.
Okay.
So that is to be played through an app.
Okay.
So again, another thing that we're trying out just it will just encapsulate what we have learned in this session in form of 10 questions.
That's good.
So last time there was a good response to it in the first session, the August session. So we thought we'll just continue and see how it goes again.
I think Pratik, you also have to make me co-host because I also have to share the screen, I think.
Okay. We'll do that.
Thank you.
You're now the co-host, Amit.
Thank you.
So it's 5:30. So whenever you say, I think we'll be on good to go.
Okay. I think we should go.
Amit, sir.
Yes, we can go.
Okay. So if you can share the screen, we'll just start the process then.
I think you introduce sir and then I will share the screen.
Okay, sure. Okay. So Let's start the September session of this Nurture the Future that has been planned by Sarcoma Education Foundation. As we know, this is an initiative to consultants in the basics of musculoskeletal oncology. We had a very good bone neoplasm. And in continuation with that, we have this September session, which is for radiology in musculoskeletal oncology. Now, this session is being chaired by Professor Rajesh Bochu. He's a musculoskeletal oncologist, radiologist from Royal Orthopedic Hospital, Birmingham, and he has been kind enough to accept this invitation on a weekend to help us for this session. He is also an honorary professor at GMISR Vizag and deputy editor in Clinical Radiology Journal. He's obviously a member of many research and education committees. His radiology training has been from University Hospital of Leicester in United Kingdom, and specific musculoskeletal oncology training has been from Geneva and also in Royal Orthopedic Hospital, Birmingham. Welcome, Rajesh Bochu, sir.
Okay. Thanks for the invite. And as Pratik has said, as a part of our initiative to improve or increase the awareness about bone and soft tissue sarcoma, today we have a varied session. The first session is by none other than Associate Professor Dr. Amit Janu. He's going to show us some common imaging scenarios. He's an eminent musculoskeletal radiologist based at Tata Memorial. So after that, we will have a lecture by Dr. Khushbu Pilania. She will be talking about the optimal MR imaging protocol. And then we will have a panel discussion. And at the end, we will have a quiz. So without further delay, over to you, Amit.
Thank you so much, sir, for the nice introduction and guiding me for this session. So is this screen visible to everyone?
Yes.
Yeah. So today we are discussing about the common imaging scenarios of the bone tumors. We have chosen this topic because most of the time what we see in our routine day-to-day practice and what are the kind of tumors that come across in our day-to-day OPD, and how we can minimize the mistakes by taking learning from these common scenarios in the future. So we have taken care of those things, and then we have created the scenarios. So this is how we have started. We are a very small group in Tata Memorial Hospital, 1 or 2 members in each department at that point of time. And now we have actually grown up to this size in 2022. And coming back to the scenario number 1, so we can see that this is a 40-year-old patient which is having knee joint pain and tenderness in the right hip joint. And if we see there are multiple lytic sclerotic lesions involving the distal end of femur, upper end of tibia, and then there is some changes, similar changes that we see in the patella. So if we go by the conventional criteria that after X-ray, we see something which looks to be aggressive or non-diagnostic, we have to follow the MRI. And in this MR picture, we will see that these opacities are seen. Multiplicity, we have the X-ray that is available. One thought was going to the mind that probably this could be infective etiology. But again, the conventional teaching always says that if it is something which is more than 40 years of old, we have to rely on our teachings that whether we are dealing with METS myeloma or lymphoma. We did a CT scan in this particular scenario, and in the left hilar region, there is a large mass sitting there. These all looks to be metastatic, and probably that the presentation of the metastatic is with the knee joint pain. So we did the biopsy from the pulmonary site, and we find out that it is the metastatic adenocarcinoma, and the presentation was with the bone mets. So the learning point is that if the patient is above 40 years, always suspect METS myeloma, lymphoma first, to rule out these first, and then we'll go for a primary bone tumor finding. Coming to scenario number 2, where we can see that this is a 23-year-old male patient, and which is having pain and tenderness in the right hip region. And if we ask in the routine quizzes, probably this kind of scenario, where is the abnormality, most of the people will get either different locations or will not able to read it out. But definitely when we did MR, there is something which is looks like, oh, we have missed this kind of thing on the X-ray. So definitely when there is a normal looking radiograph, the next level of investigation, especially in the pelvis and the exoskeleton, we have to follow with an MR. This is a case of Ewing sarcoma here, and this is how the post chemotherapy it has melted. So the learning point is here is that we have to do an MR in symptomatic patients with normal looking radiographs and non-diagnostic radiographs. We can miss tumors and we can miss infections. In this particular case, absolutely no change in the bone, but the moment if we do MR, you will see that a lot of osteomyelitic changes has been seen. In this case, the fat is preserved in between that we called as fat sign for infection, and it was an osteomyelitis in this case. So we have seen that we can miss infections which is large enough, we can miss a tumor which is large enough in a normal looking radiograph, because the osteolysis that is required to recognize a radiographic pattern is almost 30 to 40% before actually we can see with our eyes. Coming to scenario number 3, here we can see that again, it is a normal looking radiograph. She is a pathology resident, which is she is having pain in the foot. The symptoms were exaggerated on walking, but we haven't seen anything abnormal on the radiograph. And after that, because the symptoms were persistent, we see that there is an edema which is there into the bone. There is some edema into the soft tissues, and which is unexplained. Though there is looks to be subtle hyperintensity in this particular cortex, and there is some elevation of the cortex. At the time we repeated the radiograph, and we saw that there is a definite periosteal reaction. There is a lucency in that particular case, and it is a stress fracture because she is coming up and down every day for the 8 floors. She is working to reduce the weight. So if we see that if we come across unexplained marrow edema on MR, we have to suspect certain possibilities, and we have to suspect stress fracture, osteodyma, and infection. In this particular case, we see that there is an exponential amount of edema on star imaging. If we see there is a nidus here that is sitting into the T1 weighted images, and if we corroborate the CT images, we can see that there is a very well-defined nidus that is seen on this particular case. So if there is an unexplained marrow edema like this, which is out of proportion, and if we are unable to see the lesions, we have to see for these clues whether it is a thin hypointense line which might mimic like a stress fracture, or a nidus which is looking like an osteodyma, or there is something which is non-enhancing central component into the cortex, which could be a cortical infection. Coming to scenario number 4, we can see that this is a 4-year-old boy with pain and swelling in this particular scenario. Pain and swelling in the particular scenario, and sorry. So we see that there was a long history of pain here. There is some history of trauma here, and what we see here is that there is a soft tissue lesion here, which is throwing exponential edema. And in the corroborative MRI, we can see these findings. So when we see any soft tissue lesion which is having an exponential edema, then we have to suspect myositis ossificans. In this case, there was a fibrous cortical defect here. There was a swelling that was seen, and after that, the MRI has been done. When the patient presented to us, we did a simple radiograph, and we can see the maturation of the myositis ossificans, which is typically having the this kind of pattern. So the learning here is that when we see lesion which is having an extensive soft tissue or muscle edema on MR, we have to suspect myositis ossificans. And these cases can present in any of the modalities. We can come across these cases into an X-ray, and these might present with an MR at some point of time, might have an ultrasound for a biopsy, or it can be a CT-guided biopsy in which we can come across. So if we see thin hypo-intense rim of calcification and edematous changes, we have to suspect probably we are dealing with an, how we will prove it, we either have to do an X-ray or we have to do an CT just to confirm whether we are dealing with an myositis ossificans here. So always remember, any lesion which is in the soft tissue throwing exponential edema, please rule out myositis ossificans. Coming to scenario number 5, in this case, we will see that there is a path fracture here. There is some osteolytic lesion that is sitting here. Looks to be well marginated here. And on the follow-up X-ray, we can see that the lesion is actually remodeling, and there is not much of edematous changes, periosteal reaction in the present scenario. So definitely we have to identify no-touch lesions, and these no-touch lesions can sometimes be complicated by the pathological fracture or other associated complications. In this particular case, we see that it is a very classical presentation of a simple bone cyst in the proximal metaphysis of the femur, and subsequently we will see that there is a remodeling changes in this, and probably in future it will resolve, and we will not able to appreciate whether there was any lesion in this femur or not when the child become adult. So it is easy to pick up when it is having a classical presentations, but if there is a fracture or these things can be complicated, and we have to do a serial radiograph evaluation if available with us to identify whether it is just a no-touch lesion which has in the remodeling phase or healing phase. We have to identify. So other tumors which can present in this category are the lipoma, which is typically located into the calcaneum, fibrodysplasia having a ground glass matrix, and thick rind of cortical thickening here, and ground glass opacities, cortical lesion within very sharply marginated sclerotic rim, and that is the non-ossifying fibroma, and anterior shim region, cortical lesion, long-standing, probably it is a osteofibrotic dysplasia. Again, we have lesions which is throwing cortex containing with the cortex, medulla containing with the medulla. This is typical of osteochondroma. And in the digits, when we will see that expansile lesion with ring and arc-like calcification, sharply marginated geographical lesions are the enchondromas. Coming to scenario 6, we come across the lesions which looks extremely benign, but the moment we will do NMR, we will see that it is having a lot of edematous changes, having surrounding reactive effusions into the joint. And these are the lesions when we think probably we are dealing with lesions which are going to be benign, aggressive. Benign because it looks to be benign on X-ray, and the moment we will do NMR, we will see that it is throwing up an edema around the well-marginated lesion. So probably we are dealing with the benign aggressive lesions in this category. So always remember, if something which is looking benign on X-ray and having marrow edema on MR, these are the features of the benign aggressive neoplasm. In this particular case, it is a chondromyxoid fibroma, which is typically eccentrically located in the proximal metaphysis of the tibia and the unfused skeleton. And one margin is actually looking like a cookie bite here. And this is the typical presentation of a CMF, in which if we do NMR, we will find out all the components having a chondroid areas, myxoid areas, and there are some fibrous areas which are T2 hypointense. Going to scenario 4, when we have a very well marginated lesion, and at the time we will think that whether this is going to be a benign or whether we can probably tell whether this lesion is falling into a no-touch lesion or a lesion which has to be followed, or this lesion has to be biopsied. We have to study the margin of that region and the reaction with the host bone. So the pattern of bone destruction, which is usually an indicator of biological activity of the lesion, it will tell us regarding the behavioral significance of a particular lesion, whether it is an aggressive lesion or it is a benign aggressive lesion or probably an no-touch lesions. And we have to look for the other host responses like periosteal reactions and the interface between the lesion and the bone. So Lodwig has given this classification of the 5 grades, which we usually came to know with the Lodwig-Maxwell classifications. But Lodwig has given extensive variables, 14 variables, what he has studied in the Codman Bone Registry, and he came up with the 3 pattern of destruction. One is the geographic. If we see into the geographic pattern, that is the type A, if it is with the sclerotic rim, it usually indicates that the chances of benignity are more than 95%. If the sclerotic rim goes off, the probability of a benign still reduces, but the moment it will become a moth-eaten pattern or a permeative destructive pattern, it will indicate that the lesion is aggressive. And it has to be biopsied to know the nature of the lesions, even though sometimes it is very classical for one or other thing. So this is how the geographical lesion looks like, where we can actually sharply demarcate with a pencil sharp margin regarding the geography of a lesion. In this particular case, it is a simple bone cyst in the central medullary region in the proximal metaphysis of the metaphysis of the humerus. This is a cortical lesion, the non-ossifying fibroma, which is very sharply marginated. And again, GCTs can have a sclerotic rim, but most of them will not have, and they are eccentrically subarticularly located lesions, and ABC again fall into the same category. The thing what we talk about the permeated and moth-eaten destructions, where we'll think that if there are 2 or 3 millimeter size of lucencies that we can come across, it is probably indicate that there is a moth-eaten pattern. But if we are unable to differentiate granular kind of pattern that we see in the bone and the margins are difficult to assess, these are called as permeations. And it will usually indicate that probably permeation we will see in round cell tumors or relatively higher grade sarcomas here. And these are usually associated with the large soft tissues and incomplete periosteal reactions. So there are a few things to see when we are actually assessing the margins. We usually have to see a combination of patterns along with the geography, and whether there is any new bone deposition is there, whether the rim is regular all around the lesion, it is having some lobulations, or it is some multicentricity, or there is some area which is looks like moth-eaten or permeative. The higher grade, we have to give that grade, even if it is present in 25% of the circumference. So definitely we have to see the margins. In this particular case, it was looking like a looking like a grade 1 chondrosarcoma, because there was an endostellar sculpting ring and arc-like calcification. We did a biopsy to prove the same, because every lesion which has to be undergo a surgery or some kind of intervention have to be proved. And this turned out to be an unchondroma. And then because the patient, there was a benign diagnosis on the pathology, the patient was not filling for a major resection surgery or a curettage. He wanted to do a follow-up investigation for the lesion, and actually the region remains stable over these years. So we have to look for the changing pattern in the margins to denote whether the lesion is benign or it is having some changes which are looking like an more aggressive. Regarding this, Lodvik has given a beautiful paper in 1964, and he studied that benign tumors are mostly falling into category of type A, which might have sclerotic rim. So even we can see that a chondroblastoma, the maximum presentation with a sclerotic rim, but it might present without a sclerotic. But chondroblastoma will never occur into category 2 and category 3 lesions. Similarly, giant cell tumors will not have sclerotic rim like that of the chondroblastomas. And they can sometimes invariably fall into a moth-eaten category, but again, never present as a permeation category. What he find out that the more the benign characteristic of a lesion, there is a delay in the diagnosis. And the more the aggressive kind of pattern of bone destruction, there is a, these patients will present early. What he see in the malignant bone tumors is that the bone tumor, even though the histology will same, in this particular case, it is a fibrosarcoma. He has studied that the fibrosarcoma can have a benign presentation, can have a type like permeative destructive pattern, but those fibrosarcomas, which looks to be having a sclerotic ring or well-defined geographical lesions, are having a later presentations, and their 5-year survival is almost around 50%. The moment it become a permeative fibrosarcoma on histology and permeation on the radiology, the 5-year survival is very dismal. It is just about 7%. So even though the same histology, but the relationship of the growth rate can only be done with the radiology, and this is something we have to learn on the day-to-day radiology. So he has given extensive work on synaptic reporting versus AI way back in 1980s, why one should move towards the artificial intelligence, because we sometimes don't follow the same pattern to study a bone tumor. Which factor have to give more importance, whether the pattern of destruction has to be kept first, or whether the cortical periosteal reaction has to be given as a second point, or whether the expansion has to be given a third point. These we don't do. So we usually rely on much more on the visual impression and the background memory. But if we incorporate a pattern in our reporting, probably we will be much wiser, and that's how the AI is resulting into the future. So he has a lot of work in the descriptive and decision model and probability metrics. Who should do this thing, and if the grade is improperly assessed, how we can actually improve the accuracy and go down in the numbers of the reading errors, and what we have to do the changes, how we can actually make our diagnosis, which is less subject to the humans. So he has great work in that pattern also. So apart from geography, I would like to conclude about the periosteal reaction. If these are solid like this, which is having a continuous indolating periosteal reaction, this will indicate a benign. In this case, it is a stress fracture leading to a periosteal reaction. In this case, an infection leading to the solid periosteal reaction. The moment it will become incomplete and having a soft tissue surrounding and wide zone of transition, we have to indicate that probably we are dealing with an aggressive lesion. Again, coming to scenario 8, where we can see a lytic sclerotic lesions, large soft tissue, and do an MR, find out that large soft tissue and lot of reactive lymphadenopathy. So infection can also mimic like malignancy, and we have to look for subtle clues here. So coming to scenario 9, even though sometimes we are able to see that it looks to be probably benign or probably malignant, looking for what could be the nature of the lesion, whether it is fibrous or whether it is osteoid or it is having cartilaginous. In this particular case, we can see that ring and arc-like calcification, which is having a corroborative findings on MR. And so the important thing is that matrix is usually described conventionally a feature of X-ray. However, MR also contributes significantly, especially when we are dealing with the fibrous and cystic bone lesions, to differentiate between them. So if we see a cloud, fluffy-like opacities, this is a very classical presentation of an osteoid matrix. If we see ring and arc-like matrix, then probably it is an cartilaginous matrix. And if we have a ground glass opaque kind of matrix, then it is an fibrous matrix we are dealing with. So definitely these are two scenarios. This was looking like a fibrous dysplasia. On histology, it turned out to be hydrated cyst. And this was looking like a expansile giant cell lesion, or a probably ABC. It was actually a FD that came out to be. So definitely, if it is a T2 hypointense lesion, probably we are dealing with a fibrous lesion. It is T2 bright, then probably we are dealing with a cyst. This is having a floating membrane in this particular slide. Sorry. So coming to scenario number 10. We can see that there is a 10-year-old boy which is having significant pain, especially after he was coming from the play or playing karate. And then we find out that there is a cortical thickening, there is extensive marrow edema. Sorry. There is an extensive marrow edema on MR, and there is a thin hypointense line here. We see a solid periosteal reaction here, and the diagnosis of a stress fracture was made. So don't interpret MRI without radiographs. Coming to scenario 11, these come across many fractures, and please identify whether we are dealing with a pathological fracture, because if we put or if the orthopedician put a nail, it is a contamination of that particular area, and eventually the patient has to undergo a much bigger surgery than what has been anticipated. So our role is to identify whether the fracture is a path fracture or it is a routine traumatic fracture. Coming to a common confusing scenario where we come across that we try to diagnose an MR, and then we'll see that there is a fluid fill level. In that particular scenario, this is a case where it is a telangiectatic OGS and having a fluid fill levels. but fluid fill levels is not an indicator of aneurysmal bone cyst. It can occur into many other conditions, ranging from benign aggressive tumors like giant cell tumors and chondroblastoma to malignant tumors like telangiectatic OGS and metastatic pattern like if you are having a papillary thyroid carcinoma metastasis. Again, sometimes we come across the skip lesions. Not every lesion that we see on MR, apart from the primary, is going to be skip lesion. Sometimes we have enchondromas and other bony islands and other tumors. So try to look into the finer features before labeling that it is a metastatic skip lesion. So just to come to the final conclusion slide here, that age is a very critical factor. If it is something which is more than 40, look for metastasis, myeloma, lymphoma. And if the radiograph is available to us, try to ascertain these features, which is the margin, the periosteal direction, the soft tissue component. If the radiographs are non-diagnostic or looks normal after evaluation, evaluate further with the MRI if the patient is symptomatic. And if you find out unexplained marrow edema, try to see the osteoid stress fracture, cortical osteomyelitis, and sometimes CT might be helpful in these particular scenarios. If they are diagnostic, try to characterize whether it's a benign touch-me-not lesion or a benign aggressive lesion, which need further evaluation with the MRI, or sometimes an aggressive lesions, and try to differentiate between whether it's an infection or it is an aggressive bone neoplasm, probably a sarcoma. Try to tell apart from that if it is an aggressive lesion, whether it is osteoid or it is cartilaginous or fibrous, or it is having some non-matrix lesions in case of malignancy, which could be Ewing's sarcoma, lymphoma, or plasma cell neoplasm. And we have to remember the tumor mimics, which is the myositis ossificans, and the path fracture that we'll come across, and the fluid fill levels that we come across in the routine practice. So just to enumerate that these concepts are statistically valid, and Lodwig has studied that across the hospital and continents, and these are still very useful. And the best thing is about them, they are very natural and easily followed. And we just have to remember the 5 descriptive signs that he has enumerated. So even though we cannot sometimes tell the exact nature of the disease, even if we can tell the rate of the growth of the lesion, it will actually rationalizes the approach to the management of the bone sarcomas. So with that, I would like to end the session. If there are any questions, probably we try to cover into the panel discussion. Over to Rajesh sir, if anything he like to add. Thank you.
No. Thanks a lot for the excellent talk, Amit. In view of the time constraints, so I would like to invite Khushbu to talk about the optimal imaging protocol. Khushbu, over to you.
Is my slide visible?
Yeah.
Yes, it's visible. You have to just make it full screen.
So at the outset, I would like to thank the Sarcoma Education Foundation, Dr. Rajesh, Dr. Amit Chanu, Dr. Ashish Gudia, for giving me this chance and opportunity. What I'll be doing over the next 10 minutes is taking over from where Amit left, in the sense that he's already given us the common case scenarios where we need to do MRI. He's already set across the point that MRI is not for diagnosing a bone tumor, but it is for further management. So that is why it is very important that we know how that MRI needs to be done. So that's what will be the essence of this talk. And we will see that why an MRI is to be done and what should be the adequate protocol so that we are able to answer the relevant questions. The most important thing is that MRI is not done to diagnose the tumor. In more than 90% of the cases, the diagnosis is always there. It's only in the dilemma cases where, yes, MRI helps us in making the diagnosis, but more often it is done for staging the disease, for preoperative planning. Yes, as we said, when radiographs are equivocal, in those cases for establishing a diagnosis, and then for planning a biopsy in a patient. So these are the important reasons why we do an MRI in a bone tumor. When we talk about staging, doing an MRI for staging, what is the information that is expected from us as radiologists by the operating ortho-oncosurgeon? So they want to know the extent of the tumor, whether the tumor has crossed the physeal margins, whether it has involved the joints, whether the neurovascular bundles are involved, are there any skip lesions, and how much is the intratumoral necrosis, which becomes important, especially in cases which are being treated with neoadjuvant chemotherapy or chemotherapy otherwise. So these are the important information which we need to answer. We may not give a diagnosis of what bone tumor it is, but if we are able to give all these answers, our work is done. For this reason, how to scan? Most of the times when a bone tumor is seen on a routine scan, the idea is to just focus all scans on that particular region, do all variety of sequences available, and it takes, I don't know how much time. And most of the times the answer which is needed is not given. So it's important to protocolize it. How we do it is, we do a focus study of the region with tumor and include one of the closest joints. So for example, if I'm scanning a tumor in the distal humerus, then I will include the elbow joint in my field of view and do a dedicated scan of that part, so that I have a high resolution scan to answer questions with respect to the nature of the tumor and its relations to the neurovascular bundles. Post that or prior to that, we need to do a plain T1 weighted image of the entire limb in such a manner that both the joints related to the tumor are involved. So the scan should be done in a manner, for example, if we're still dealing with a distal humeral lesion, the shoulder joint as well as the elbow joint should be included in my field of view, so that I can give the dimensions of the tumor in relation to both the joints. The distance of the proximal and the distal margins of the tumor from both the joints should be given. So, and in most of the cases, a plain T1 suffices, especially in cases where the soft tissue component is much higher. A post-contrast screening T1 is also helpful. And preferably, especially when we are doing the lower limbs, we should scan both the limbs together. It is often helpful, especially in the patients who've been treated with neoadjuvant chemotherapy, because often chemotherapy induces some changes in the bone marrow, reconversion, etc. happens. And if we are screening both the limbs together, we have a decent comparison, which helps us differentiate quite often between some skip lesions versus marrow reconversion. Followed by a dynamic contrast enhanced scan with mean curve analysis whenever we are administering contrast. So if we are administering contrast, it should be a dynamic contrast, and I will highlight the importance of doing it in the dynamic fashion rather than doing the single shot imaging. So having said that, what protocol do we use so that all of these questions are answered and addressed? First, we do a coronal stir and T1 of the focused area, including one of the closest joint, a sagittal T2, and all these axial stir T1 and T2 weighted images. Then we do a dynamic contrast study, and we do post-contrast T1 FATSAT in all the 3 planes. After we've done all this, then we decide basis. If the tumor has a large soft tissue component, we do a post-contrast fat-saturated large FOV imaging. If it is predominantly a bone lesion, then we do a non-FATSAT T1 weighted imaging, because the bone marrow involvement by the osseous component can be picked up much better. And this large FOV scan will include the joint above and the joint below the tumor. Now, then once we've done the scan and we are reporting, it is of utmost importance to give measurements. A lot of measurements need to be mentioned because they are helpful. And how these measurements are done. So we need to give the largest dimensions of the tumor, all 3 planes, followed by the dimensions of the soft tissue and the osseous component separately, and their relationships with respect to the closest bony landmarks. So for example, in this case, I say that the osseous component is X centimeter. The proximal margin of the osseous component is X centimeters from the knee joint line or the articular surface of the femur. Similarly, the proximal margin of the soft tissue component is Y centimeters from the proximal articular surface of the femur. So these measurements are of importance. Then we need to tell them whether, yes, the physeal plate is involved, whether there is extension into the joint space, whether the ligaments, etc. in the joint are involved or not. So these informations are important. So we need to give that. Then we need to tell them whether the neurovascular bundles are important. So in this case, we clearly see that the femoral neurovascular bundles are completely encased by the tumor, whereas in this case, they are spared. So it is very important to mention these findings. Look for skip lesions. So as Dr. Amit also mentioned, we need to look for them and at the same time differentiate them from mimics like marrow reconversion, bone islands, etc. A good way is while doing the contrast, if these lesions are included in the field of view, we have our answers. At the same time, scanning the opposite limb together, especially which is easy with lower limb tumors, we can get quite many answers there itself. Then the intratumoral necrosis. What is the extent of intratumoral necrosis? It has increased versus decreased from the previous scans if we have them in place. That helps a lot. So after this basic protocol, we talk about how to enhance the role of contrast in MRI of the bone tumors. When we do contrast, it should be a dynamic contrast imaging. What is a dynamic contrast imaging? It is nothing but ultra fast acquisition of the MR images while the contrast is being still administered. So when we do that, we not only get the morphology of the tumor, but we also understand the biology of the tumor. That is whether it takes up contrast very fast and it washes out the contrast very fast, or it takes up or it pulls in the contrast. So all of these dynamics are assessed very well and they help us ascertain the nature of the tumor. So it just takes, another important thing is that it takes just 4 to 5 minutes of extra time within the machine. So not a huge trade-off. How to analyze these mean curves? So for example, in this case, on the dynamic study, we see this nidus enhancing very well. When we do a mean curve analysis, we see a typical arterial phase enhancement and washout, very typical of the osteoid osteoma. Similarly, another case where I'm seeing a mean curve analysis, which shows me a gradually progressive enhancement pattern, which shows that it is a lesion which is pooling in contrast. Most of the bone tumors have neovascularization. They do not pool in contrast as much. So we have a contrast flushing in and washing out with bone tumors. This means that it is more of a benign lesion. Another case where we are seeing again a moderate enhancement, but here we are seeing a plateauing. So plateauing comes into a gray zone where it can be aggressive or a benign lesion. With respect to the mean curve analysis, we need to see the rest of the characters of the tumor to characterize it. Another aggressive tumor where we see a pickup, but not as much as the arterial phase, and we see a washout. So this means that the lesion has more of neovascularization. The same example again, which shows that this was a metastatic tumor and it showed the aggressive pattern of enhancement on the dynamic study. Again, the image of the osteosarcoma where we saw that the lesion was showing a moderate, a gray zone pattern on dynamic, but it was an aggressive tumor as seen by the characteristics of the lesion on the routine scan. Now, this was again an aggressive looking lesion involving the tibial metadiaphysis. We did the dynamic contrast. We could see the gradual progressive enhancement, which increased our confidence that this is a benign lesion. We could very well see the fat sparing sign described by Dr. Amit as well into this, which shows that it's a benign lesion. But just to add on to the fact that yes, dynamic contrast helps in cases of dilemma. Another tumor where it's a typical chondroid matrix, the dynamic contrast curve was rather flat. So this increased the confidence that we're dealing with a benign lesion, and further plan can be on those lines. This was an interesting case where this 14-year-old girl was had an ablation for osteoid osteoma, and she came with this recurrent focal lesion. There was a strong suspicion that this is osteomyelitis, which has complicated the treatment of the osteoid osteoma, but the dynamic curve showed something else. We could see the typical pickup and washout, and it turned out to be a recurrence of the osteoid osteoma. Another companion case where we could see this focal lesion into the tibial marrow, and there was a suspicion that it's an osteoid osteoma, but the dynamic curve did not show an osteoid osteoma pattern, and a follow-up scan, which I'm showing below, showed regression while on antibiotic studies. So just to sum it up, that malignant lesions usually show a type 3 or a 4 curve, which means uptake with plateauing or uptake with washout. Benign lesions usually show a gradually progressive enhancement or an arterial phase uptake, like seen with osteoid osteomas and also giant cell tumors. A characteristic arterial enhancing nidus often increases our confidence of the lesion being an osteoid osteoma. So just to say that a conventional single snapshot post-contrast imaging details are much enhanced when we do it in a dynamic fashion. It also gives us the angiography phases wherein our assessment of whether the arterial neurovascular bundles are involved or not increases multifold. And as I said, it takes only 4 to 5 minutes of extra time, no special machinery, no special sequences, no special protocols are needed. So this can be done. And essentially, the idea is that whenever contrast is given for a focal bone or soft tissue lesion, we should try to do it in a dynamic contrast enhanced fashion. Thank you. So in case there are any questions, I can take them.
Thank you for the talk, man. There are a couple of questions on the chat box. So if I may ask that. One is how to differentiate between the physiological bone marrow changes and the bone marrow changes due to tumor in MRI.
So when we want to differentiate between them, one important thing, as I mentioned, is when we compare the adjacent bone, we compare the enhancement pattern and the marrow signal pattern. Another important change is the fat sign. So when it's a physiological marrow change, the interspersed fat is preserved. We will see islands of fat preserved between the marrow changes, whereas in the other case, the islands of fat will not be preserved. Epiphysis is usually spared when it's a physiological marrow change versus when it's a pathological marrow change.
Thank you for that. And the second question is, what is the sensitivity and specificity of dynamic contrast enhanced imaging?
So when you say sensitivity and specificity, it is with respect to diagnosing a bone tumor. I will not say that there is any specific, when I say, I can use it in a specific term. So if you ask me sensitivity and specificity for an osteoid osteoma, so it's highly specific for an osteoid osteoma. At the same time, the sensitivity is also high. So it varies from one bone tumor to another. If we talk about...
Hello, sorry, go on.
Yeah. Yes. So that's... I can read the next question myself.
Yeah, that would be great.
So the role of diffusion weighted and GRE in bone tumor imaging, do you routinely perform these? Diffusion weighted, yes. GRE, not always. Diffusion weighted imaging, the role is because with the way we can calculate the ADC map, especially in cases where the patient is on treatment, it often helps us assess how the treatment is progressing. And GRE picks up PVNS. Yes, it does pick up PVNS. So in case you're suspecting PVNS, we can add GRE to our protocol. It's not a part of a routine protocol to use GRE in it.
Just one more question. If like what we get frequent queries from our orthopedic colleagues, like if there's a compression fracture in the spine, so if you have to differentiate between a traumatic cause and a pathologic cause, is there a way to do that with an MRI?
One of the very interesting ways, one is of course diffusion often helps, and another interesting way is start using the T1-Dixon sequences. So when you use the T1-Dixon sequences, often in cases where it's an osteoporotic compression, we see a significant signal drop between the in and out phase images. And that means that there is fat within the lesion. Once there is fat within the lesion, we know it's a benign osteoporotic compression.
Benign osteoporotic. Okay. Thank you for that, ma'am. And I think, Amit sir, we can start with the panel discussion. Professor Bochu, if you have any word on these two talks that we had, if you can just add a few words of wisdom from your side.
No, that was an excellent talk by Khushbu. So the MR techniques are different in different hospitals. So we are a major tumor center. We see about 50 bone and soft tissue sarcomas a week. So we tend to use only standard sequences, which is T1 and STIR coronal and T1 and T2 fat set axial. We don't use contrast at all. In fact, we have done a couple of studies looking at dynamic contrast for chondrosarcomas and other tumors, but it doesn't help us at all. We have used diffusion as well, and that doesn't help either. So hence, our protocol is very simple. T1 and stir coronal of the whole limb and T1, T2 fat set axials.
Okay.
But obviously,
you simplified your protocol a bit.
It's very easy because we have gone through all the loops of dynamic contrast, post-contrast, diffusion, everything. So we found that just simple sequences itself should help us in getting the diagnosis.
Totally agree, sir. So it's just that if contrast is needed, we've realized that it helps, and otherwise it's not a mandate. So for every bone tumor, even we don't do contrast unless it's been asked for.
Oh, okay, because the general traditional learning that we in orthopedic onco conferences have is that if it's a bone tumor, you ask for an MRI with contrast.
No.
So is there a change now as we know more about these things, or is it like you need specialist musculoskeletal radiologists who then can study the limited sequences? Like if Birmingham has Professor Bochu, so they can, I think, get afford to limit the sequences, whereas all the centers may not have a specific musculoskeletal radiologist. And in that case, would you still then say ki simplify it, or would you then say contrast is required in these sequences?
Well, in my opinion, I think based upon normal sequences in conjunction with radiographs, especially for bone tumors, you should be in a position to come to a sensible differential diagnosis, what the lesion is. And we feel that contrast does not add extra. The other problem is contrast is not like, it has its own complications. I know we use very little GAD, but you can see several papers. And in fact, if you go to Switzerland and if you eat a burger in Switzerland or Germany, you're basically drinking GAD, and nobody knows the long-term effects. So hence we have stopped GAD. We don't use GAD for majority, even for arthrograms, we don't use GAD. We use just normal saline and lignocaine. But so I tend not to use GAD at all. Very minimal GAD except for post-surgical spines. For bone tumors, it does not add any extra information.
So anyways, at all times, we always say that the diagnosis is made on radiograph. So MRI is seldom done to diagnose the tumor. So then if the idea is there that you're doing it for for staging the tumor, unless there is a very,
No, for staging only, I'm saying. So if you think it's if you can see the skip maps on the plane, T1 and STIRS, you can see neurovascular bundle involvement, joint involvement, extent of soft tissue, you can tell them the resection margins. And that's what they want. Those are the main key features that they want.
So what is your take on the
I
patient?
think we can go to the panel actually. Otherwise, I think our time will go on.
Yeah. Okay, panel discussion. Yeah.
Yes.
We will discuss these points coming into the panel. Can I share? Is the slide visible?
Yes. For title screen is visible.
Okay, fine. Thank you. It is not moving, but I just.
But till you sort that out, I'll just refer to the chat box question, because Dr. Khushbu mentioned that MRI is not used for diagnosis, because that was one of the questions asked on the chat box. If you're going to do an MRI, then why do a radiogram? So I think that point is now clarified with what Dr. Khushbu and Dr. Rajesh have said. The radiograph is your first line of investigation, and then just for those additional information for planning, you get an MRI done. Okay, Amit sir is ready, so let's move on to.
Yeah, thank you, Pratik. So now we are moving to the panel, and we will discuss these questions in the appropriate case selections. So basically, we have just simplified these questions so we can for a wider participation of the younger radiologist colleague and the orthopedicians and other specialties. So So today, I would like to invite Amit Karat, who is from Pune, and he's actually extremely interested in AI, and he's also working on some other parts of AI as well. And we will ask him what the AI is doing in musculoskeletal oncology. Anindita, she is my very good friend and colleague from PJ Chandigarh. Then Anirima, she is our ex-student and now she is consultant at Tata Medical Center, Kolkata. And Ekta, again, my good friend at AIIMS Delhi. We will see. Then Nikshita, she is again our very good student and she is currently faculty in CMC Vellore. Anindita, my own colleague in Tata Memorial Hospital, Mumbai. Rahat Barar, who is my colleague in HVCH Mulanpur, Chandigarh. Dr. Rajesh Bochu, I think he is giving opinion probably in every case, so he's there. And Suman, he's orthopedic oncologist. He was our fellow here in TMH, and now he's practicing in NH Bengaluru. Dr. Subin, I'm thankful to him that he has accepted the last minute invitations. He's orthopedic oncologist and he's every year organizing some or other thing to educate Sarcoma Society. And then Poonam Panjwani, my colleague at TMH Mumbai, she's pathologist. Kunal is
Amit sir, before you start, just sorry for the interruption. Dr. Suman and Dr. Subin both have not been able to join. So if there is any query for the orthopedic oncosurgeon part, I'll be happy to help.
Again, Dr. Kunal Gala, he is my very good friend and interventional radiologist. We will involve him in the panel discussion. And Amit Chaudhary and Khushbu can also participate. They are faculty in today's program. So I am discussing a very basic case here. Sorry. So 56-year-old female from India of Maharashtra, and she is having heel pain. So my first question is that what does the lesion looks like? So probably she is having pain, and this has been evaluated by some maybe a general practitioner or an orthopedic person, and this is the X-ray done. So what is looks like? Dr. Bochu and Dr. Khushbu, Anindita, everyone, please, you can answer this.
Well, what you can see is lucency in the posterior part of the calcaneum. It's got a wide zone of transition. And there is some, we can't see any matrix. And there seems to be some, I don't know whether there's a fracture or because of the fracture, there is some callus or there is some newborn formation inferiorly as well. And she's young, 56. So irrespective of the location, any person with destructive lesion, more than 40, as Amit said, metastasis, though below the knees, is rare, but that still will be in the top differential diagnosis. Metastasis and myeloma will still be in the top differential. So normally in these cases, you do a CT chest abdo-pelvis to look for primary and an MR of the ankle.
Okay. So you will calling it as an aggressive lesion. So I think Ekta or Anindita or Nivedita, you have the same opinion like Dr. Bochu has given in this particular radiograph.
Yeah, but in our scenario, we also have a lot of infections. So I would like to know whether this patient is diabetic or not. Although this is a very atypical lesion and doesn't have in the midfoot or forefoot at least no neuropathic changes, whether any trophic ulcer was there and the skin was normal. Infection is always at the back of our minds before we really see what is happening, and the local skin or something would be able to give a clue as to a sinus tract or a chronic discharging condition. Sometimes you can have atypical infections, not only these sinus tracts, but fungal infections also, although it's very atypical.
So definitely, again, probably it is aggressive, whether it is a malignancy, primary malignancy, metastasis, or infection. I think Anurima and Nikshita, they can also, if we want to give 4 options, whether it is feeling it is a touch me not lesion, or it is a benign or benign aggressive or aggressive, what is your opinion if you are sitting in a Tata Medical Center and want to give an opinion on this X-ray?
I totally agree, sir, with the other panelists, and I would definitely like to put it in the category of an aggressive lesion, given the age of the patient, and also like this kind of a lytic lesion. I do not see any sclerotic rim, or I do not see any soft tissue component. But definitely, given the age of the patient, a lytic lesion, we will need a biopsy. And metastasis is definitely going to be at the top of my differentials.
So I think everybody is agree that this particular lesion is looking aggressive. Then the next level of investigation has to be performed. So whether it has to be followed by CT of the local part or MRI of the local part, or we have to do a PET CT scan and biopsy. I just want to take an opinion. What is the practice in the North India or South India or eastern part of India? So what we will do in this particular scenario, and then Dr. Borchu will guide us what is the appropriate thing that has to be done. Anandita, what is your take on what you want to do first? Actually, you want to do MRI first, or you want to straight away go with the biopsy?
No. I would first of all do an MRI and then try to see the internal. As Dr. Khushbu also said, a little bit of idea about the matrix. There is no mineralization on the radiograph at least. So the MRI would give an idea about what the matrix is like, whether there is again another penumbra sign to sort of guide us, and then proceed later on with the biopsy after the MRI. And depending, first of all, of course, as Dr. Borchu suggested, CT scan not of that local area, but CT scan of the entire chest and abdomen. And
Chest and abdomen.
Yeah. If
Okay.
that shows metastasis, of course, then you go to a PET. It depends upon what is happening. So if the local examination reveals that there is no superficial soft tissue or bogginess, redness, all the erythema, dolor, color, rubor of an infection, then straight away think of metastasis, get a CT scan of the chest, abdomen done, and then if necessary, get a PET CT and biopsy from whatever site is easily accessible. But otherwise, if there is nothing on the CT which is non-diagnostic, then go for a MRI and biopsy. So it will depend upon the scenario.
Is Rahat there, and Rahat or what is Ekta? If they have some different opinion. So Dr. Borchu, what you would like to do in this particular scenario?
I would do an MR first. It's obviously, as everybody said, clinical information we need, but MRI will be first.
So
I just wanted to ask if there is any history of any known malignancy in this patient.
So we don't know as of yet. This is the lesion. MRI has been ordered, and this is how the MRI looks like. So again, we are persistent with our X-ray diagnosis, or after MRI, we want to decrease it, or we want to upstage it. What we have to do it?
It will still remain an aggressive lesion. There's a lot of bone marrow edema. The lesion, although is well demarcated, but adjacent inflammation is too much. So again, it depends upon whether it's in 40 years old age group, it's a METS or a metastasis or an atypical. It doesn't look like a chondroblastoma, but again, in this age group, calcaneum can have a chondrosarcoma if it's not a primary, if it's not a metastasis or a myeloma.
Okay, so the patient, actually everybody has correctly pointed out that it looks like to be aggressive lesion, and I think age is definitely an indicator which points towards that. If it's something which is more than 40, even though some atypical sites and atypical looking lesions, probably our first role is to rule out METS myeloma lymphoma. This patient actually probably treated 20 years back. He's not remembering that what she has been treated for, and after 20 years he has presented to somewhere, and once it is biopsy, it turned out to be an squamous cell carcinoma without having any loco-regional recurrences. She presented with this metastasis. Going to case number 2, I think this is the 20-year-old female with the pain and swelling in the so pain and swelling in the right gluteal region since 6 months. My question is that, does the radiograph looks normal? So she is having some issue probably because there is a swelling, I think there has to be some abnormality, but still, how many will raise that the radiograph looks normal or abnormal?
Amit sir, before we answer that, there was a question on the chat box. Is there any X-ray feature to differentiate between a primary bone neoplasm and a metastatic bone neoplasm? If you could answer that before this question, that would be great.
So definitely, we don't have any particular feature. So these lesions will look aggressive. But if we have a very corroborative thing like having an osteoid matrix, having a periosteal reaction, there is a soft tissue component which is also having ossified areas, and probably a ring and arc-like matrix mineralizations, having endosteal scalloping. So unless the features are very conclusive for some primary bone tumor, it is very difficult to differentiate whether it is a primary bone tumor or it is a metastasis or it is something else. We can say that probably the lesion is aggressive. We have to rule out these three possibilities first before assuming it is going to be a primary bone tumor, until and unless there are very specific pointers, like we said, there is a matrix which will again point towards that probably we might be dealing with a primary bone tumor. I think Dr. Bort,
continue.
Some other opinion you can please share.
No, I agree with it.
So I think Pratik, probably I can ask if the radiologists are not answering. This is the X-ray probably.
No. There is abnormality. Definitely, we're just waiting. There is abnormality.
Yes, and even on the chat box, people are replying now, abnormal X-ray.
So I just want to know, Pratik, if they can read out where is the abnormality they are actually picking up.
The audience to answer.
Should we?
Yeah, audience can also answer. Probably
on the chat box, yeah, you can.
Chat box, they can answer.
Yeah. So we have got one answer, right? Acetabular area.
Yeah.
Yeah.
So definitely it's an abnormal, and I might give the So I am giving these four options. It is acetabulum, it is a femoral head, and ischial tuberosity and sacrum.
We have got two answers in favor of acetabulum. Ready?
So I think we can see that we can see the ischial tuberosity very well here, and I don't see anything which is fitting into this particular location. And there is some changes in the acetabulum that looks like. So now we have pointed out the abnormality. So what could be our next thought process? So what kind of lesion we are dealing with?
I think you can, but just since the radiologist is a bit hesitant, so I think you'll have to point them out and ask their opinion.
No. So I can point out, I think Anurima and Anandita, if they can take it.
Yeah, so is Anurima taking it, or should I?
Ma'am, please go ahead.
Okay, so along with this area of this lytic area in the acetabulum, what you see is that there is a displacement of the fat plane within the right hemipelvis, and there's a soft tissue density. There's no matrix mineralization. I mean, there's no mineral mineralization in this area, but also along with that, there is a large soft tissue on the lateral aspect, maybe lateral and posterior aspect, but the gluteal fat planes are the gluteal muscle fat planes are not disrupted, but on the medial side as well, there is maybe some soft tissue density here, added soft tissue density. So along with this lytic area in the right acetabulum, there's a large soft tissue component associated. So in a 20-year-old, again, it will be an aggressive lesion, and the possibility again that it could be I don't see any expansion of the bone. There is just a lytic area. So common lesions here, which are benign and have a large sort of expandile bubbly lesions, are the ABCs, GCTs, but there is nothing of that sort here. And again, but
So I just want to involve Amit Karath. Actually, he is doing a lot of artificial intelligence. If he is there, so what is the role of AI, where actually the radiologists are difficult to pick up the lesions in these complex anatomical locations? So if he is there, he can actually talk about it. and whether there is a role in triaging between normal and abnormal, or picking up the site of the abnormality through the AI. Is Amit here? I think he's not there. So, Dr. Borchu, what is your opinion here?
Yeah, so general take is that there is relatively less bone destruction, and there's displacement of the bladder, and also there's a large soft tissue component with relatively less bone destruction in a young person. So whenever you have this, you have to think about round blue cell tumor. Round blue cell tumor can either be Ewing's or lymphoma. Both histologically will look the same. So I would do, that's what would be my top differential.
So Nikshita, if you are sitting idle, what is the next level of investigation we will do in this particular scenario? Because we have to lead somewhere to give some clue what is happening with the patient.
So next we'll definitely do an MR and determine the extent of soft tissue and also the lytic lesion. And then accordingly, depending on the characteristics on MR, guide for a biopsy if required. So on this MR, we are seeing a lesion with multiple fluid levels. Given the age of the patient, I'm favoring
So I have given the age, which is probably not fitting into either of these.
Yeah.
It is probably we can have some situations like that. The age is at the cutoff where actually we cannot go on either sides.
Yes, so it's a little difficult here. Which one, ABC or GCT? I hard to tell, so.
So there's no soft tissue component here. It looks like purely fluid levels.
Okay. So if that is the scenario, we have given 4 options here actually, whether it is an ABC. Now that new terminology, we just call it as an ABC. We don't call it as a primary or secondary ABC. So it is like for secondary ABC, we are using the terms ABC-like changes. So whether it looks like a giant cell tumor with ABC-like changes, or it is having telangiectatic OGS or a vascular metastasis. So what is your opinion?
Maybe because it is like fused, looks like mature skeleton. GCT would be my first differential, GCT with ABC-like changes. Also, it is subarticular in location. If there is some soft tissue that is not in this image, then even a telangiectatic OGS can be a consideration. But I'm not seeing any aggressive features on the radiograph in terms of periosteal reaction to suggest a OGS component. I think so. That's what I'm thinking.
Definitely, age will make a difference here, probably or more than what we see on the radiograph. So if it is a complete fluid levels, what is your opinion, Khushbu, in this particular scenario? If whether you want to give contrast in this particular patient when you see on the plane sequences that there is a fluid level. I know that Dr. Borchu will now not give contrast in this scenario. What is your take on that? Is Khushbu around? Okay. Is Ekta and Rahat, they are in the panel actually. I cannot filter out if Pratik can tell about whether they are there or not.
So Khushbu ma'am is not there.
Okay. Pratik, I can just take your time. So suppose you have given all the possibilities. Radiologist has said that it could be GCT with ABC-like changes, more over ABC, and they cannot rule out telangiectatic OGS in this particular scenario. So what is your take on that?
Then in that case, we'll need a histopathological diagnosis before going ahead for the management, because the management for the 3 of them differs vastly in this area. Like if it is aneurysmal bone cyst, we can try a sclerotherapy in this area. If it is GCT with ABC changes, we'll have to go ahead either with, we'll have to then counsel the patient extensively, because then this becomes a morbid surgery. Then we'll have to discuss about denosumab versus a curettage versus angioembolization and all those things. And telangiectatic OGS, then it's a resection, and that's a very morbid resection. So before going ahead, then we'll have to get a histopathological diagnosis. And probably in this day and age, we also have those immunohistochemistries. And we'll have to do that before going ahead for the treatment.
Yeah. So definitely fluid levels will just indicate that it is an ABC-like change, and then we have to see whether it is a primary ABC, not having any other background information. And for that, probably we need in long bone tumors, we need radiographs to corroborate whether it is just and pure ABC or not. And on MR, we have to see whether the fluid fill levels are complete, not having any break somewhere, or having extensive edema or some soft tissue component, and having an osteoid-like matrix to certain that we are only dealing with ABC, because sometimes just during the biopsy, we can put in a sclerosant. And so I'm sharing some other images just to make that probably in different scenarios that the fluid fill levels are complete. And this is the post-contrast sequence that is having. So whether Nikshita, if having thoroughly seen that the fluid fill levels are complete, are you satisfied that you are probably dealing with ABC, or still you have some doubt that this could be something else?
No, so I think it's pretty convincing that this is an ABC. And yeah, probably the most likely diagnosis for this case.
So again, Pratik, in this particular scenario, you want to do an sclerosant in the same sitting, or you want to do something else? The location is something which is pretty odd.
Yes,
Probably
so in this case, we'll require the help of the interventional radiologist, because the access is a bit difficult since it's in the posterior wall. And we can do something called as a curopsy, which has been described in from Royal Orthopedic Hospital. And if while doing the curopsy there are no perforations or no breaks and all the walls are intact, then a sclerosant can be inserted. But at least a curopsy can be done while we are taking the histopathological specimen, and then we can wait for the report.
Okay. So what are the treatment options that we have discussed? That it could be a sclerotherapy. Can we observe these ABCs after biopsies, or we have to do resection in this particular scenario, or do we have other options like Kunal can tell about whether there is any role of angioembolization in this particular scenario?
So as I told in my lecture in the morning, so there is definitely role of angioembolization either with PVA particles, with denosumab or zoledronic acid. So depends on that, or that is one of the option. Another option is percutaneous sclerotherapy. So with both, the results are around the complete cure rate is around 85% in both. However, with percutaneous sclerotherapy, the rate of complication is little higher as opposed to angioembolization. With angioembolization, it is just like 5% or less than 5%.
So Kunal, do you have any specific criteria in which patient you will choose angioembolization, or whatever patients this has been referred to you, you will do in all of them?
So no. So if how symptomatic is a patient depends on that.
So in this particular patient, because it has been given a trial of sclerotherapy, but the lesion has been not regressed, and then subsequently denosumab and angioembolization sittings has been.
So yeah, as Pratik has already told, that if there are breach in the cortices, then it is very difficult to do sclerotherapy, because the sclerosant will penetrate, and probably there would be some sciatic nerve around that, which can cause injury to the sciatic nerve. So that's the reason angioembolization would work better in this case.
So definitely we have seen that when there are fluid fill levels, it is not a good sign, probably because we have to struggle between a lot of differential diagnosis to actually come up with a single diagnosis. And definitely there is a role of radiograph. I think there was a question in the chat box why we need radiograph. In this particular see that there are multiple fluid fill levels, but the moment we will look at the radiograph, there is an osteoid matrix producing lesion and the cortical plate which is looking aggressive. Definitely it is not a feature of ABC or giant cell tumor. It is looking like an osteogenic sarcoma with ABC-like changes. So it is a telangiectatic OGS. Just to Dr. Bochu, if there are fluid fill, how certain that you are able to give diagnosis in these scenarios? Probably a single diagnosis or a combination of diagnosis, what you will prefer?
So normally, as you said, if there is no thickening of septa, if there is no solid component, and age is important. Obviously, if it's 20 or 25, then you have to think about GCT with ABC. But we do biopsies of all ABCs anyway. And if there is like this case where there's a solid component and thickening of septate, then it's easy to make the diagnosis of telangiectatic osteo. But always remember, if you have multiple lesions with fluid levels, don't forget brown tumors. So brown tumors can sometimes, so every patient who has got fluid levels, like with GCT and all, always get serum calcium.
Yeah. So coming to case number 3, I have just put everything together. So we have a radiograph, 19-year-old female with a shoulder pain. I think Anirima and Nikshita, if you can make a diagnosis over that. Is Rahat is there around? Dr. Subin and Suman?
Sumin and Subin sir and Suman are not there. I cannot see Dr. Rahat also.
Okay. So Anandita, what is your opinion here actually? So,
this is a young female and there is an epiphyseal lesion with in the proximal humerus with sclerotic margins, some internal matrix mineralization, quite homogeneous internal matrix mineralization, no expansion and no periosteal reaction that can be seen. And so in this case on the radiographs, in this typical location in a young female, the diagnosis would be a it could be the typical location is of a chondroblastoma, and but the matrix is very homogeneous. It does not have a typical ring and arc sort of or stippled sort of a matrix mineralization. So, and when we look at the MRI also, the matrix at least on this is a T2 without fat sat, I think coronal.
This is T2. Yeah.
So there's a lot of hypointensity, and correspondingly, if we correspond this matrix on the T2 with the T1, there is hypointensity, which you don't expect this kind of hypointensity on a routine chondroblastoma. And there is a lot of edema surrounding this lesion also. And it is the margin on the radiographs are quite well marginated, and it is reaching up to the cortex and has a hypointense rim on this axial T1, the third image as well.
So
I would like to also keep a possibility that this is actually an osteoblastoma and not a chondroblastoma.
Okay. So Dr. Borchu, what is your opinion? Will you have, there is a typical sclerotic lesion, if on the radiograph you might have called it as a benign type 1A category lesion or type 1B category lesion, but the moment you see that there is a edema here and then there are few changes that we see. So do you agree that we are probably dealing with a benign aggressive lesion or something which is more aggressive, or we can give some category into either of the two?
Yes, I agree with everything that Anandita has said, because it looks like chondroblastoma, but the signal is a bit low. So large osteoblastomas, yes, it's one of the two. That's what I would say, because of the extent of reactive edema.
There's a question on the chat box that can it be chondromixed fibroma?
So definitely it is not fitting into chondromixed fibroma, because these are usually metaphyseal based, and one side of the cortex is destroyed, and that's why it is a typical cookie bite appearance. These have a vegetated signal which vary from like hyperintensity and having myxoid areas and chondroid areas which are typically very bright here. So that is not fitting into that. Definitely it is in fused skeleton, but it is extending both into the metaphysis and epiphysis. And we will see that the hypointensity, we have recently analyzed our data of around 60 patients in chondroblastomas, and we have seen that T2 hypointensity is a very prominent thing that is there in the chondroblastoma. It is different from other cartilaginous tumors, probably because it is a very dense cellular matrix here, which is also having a chicken wire calcifications, and these are very tightly pegged. So probably that's why, and because it is in some kind of region which is trying to be contained and a blastic lesion, that's why there is a sclerotic rim that is surrounding this, and there is a lot of edema. So it is fitting into a chondroblastoma here, and in around 70% of them will have a sclerotic rim on the radiograph. So that is our multimodality analysis that we have done in our institute. So do you think that sometimes even if we are very certain, In these kind of scenarios where we are dealing with the benign or benign aggressive tumors, where do we need biopsies? I just want to take an opinion both from the orthopedic oncologist as well as from the radiologist, that do we have to biopsy all the lesions before treatment, or can we obviate if the diagnosis is extremely certain in benign aggressive lesions, or we have to do biopsy only when the radiology findings are going to be aggressive? So just to Dr. Borchu, first I want to take your call, and then Anindita, and then Pratik.
Yeah, so if it's classic, for example, osteoidostoma or osteoblastoma or chondroblastoma, if it is classic, then we do biopsy and RFA at the same time. Or if it's large, then we can do cryotherapy at the same time. In this case, in cases like this where it is not classical, then we tend to do biopsy first, because sometimes the biopsy will be different from what you think. Hence, we don't want to contaminate, or we do a biopsy in equivocal cases. But if it's barn door, then we do treatment and biopsy at the same time.
So Anindita, what is your institute policy?
Yeah, absolutely. For osteoidostoma, we do mostly RFA and biopsy. We do RFA and biopsy at the same time. For the chondroblastomas and the osteoblastomas, we actually do a stage procedure, because our orthopedicians also want the biopsy first and then want to let us intervene. And for all the cryoablations for the chondroblastomas and the osteoblastomas, we first do a biopsy, get the diagnosis, and then proceed for a cryoablation. But it is difficult for the pediatric patients because they need then GA twice. But because of the convention, we do it as a stage procedure. But osteoblastoma, only one sitting.
Poonam, are you there?
Yes, Amit.
Yeah, Poonam, so how comfortable you are giving diagnosis on frozen sections? Because if they want to do the same sitting treatment, and to differentiate entities like osteoblastoma, chondroblastoma on a frozen section?
Frozen section is extremely difficult if we have any bone tissue. So it becomes really difficult to get a good section. We have a basic problem in cutting of the section. So if there's any bony tissue, any hard tissue, it's extremely difficult. So I think it is a good, I don't think it's a good, great practice that is followed, or a common practice. We hardly get any lesions from bone soft tissue pathology for frozen section.
Okay. So what is your opinion, Pratik, regarding the biopsy?
Sir, I agree with both Professor Borchu and Anindita ma'am. In some obvious lesions like osteoid osteoma, so we don't need to biopsy, and we can just go ahead and do it in the same setting. Here a GCT. So we need to biopsy them before going ahead with the treatment. So if, in benign aggressive lesions and in aggressive lesions, so definitely you biopsy before you go ahead with the treatment. All lesions before treatment, so that depends on the radiological findings and how confident they are. But majoritarily what we have been taught and what we follow is biopsy before you do an intervention.
Okay, so I think I will agree with that until unless it is something which is very classical, like osteoidostoma, and everyone is convinced about whether it is an osteoidostoma and very classical presentation of an chondroblastoma, we can directly go ahead with the treatment. But apart from that, any other benign aggressive lesion, before going any kind of intervention, whether it is an ablation or it is a curettage or it is a resection, we need to have a tissue diagnosis. So I think probably. What is your opinion in this thing? I think the slide is showing up, but what are the treatment options that are there in the chondroblastomas? So Kunal, I'm just will ask you. So what is your cutoff to do an ablation case of chondroblastomas?
So whenever the lesion size is 3 or less than 3, then ablation is preferred. Just because since these are young kids, can have impact on the growth plate and can have growth disturbances with the surgery. So that's the reason. And RFA has shown equally good result as compared to surgery. With the surgery, there is around 30% chances of recurrence. With RFA, that is not so. If there is some recurrence, maybe we can go again and do the ablation procedure.
Okay. So you will prefer a RF ablation or the newly entered kit into the ablative modalities, the cryoablation?
So cryo, actually in India it's a newly entered, but when you compare the results abroad, it is there since a decade. But the only is advantage of RFA and cryo is probably it's much more expensive as compared to RFA. And in cryoablation there is no pain post procedure, which is much more comfortable. We can do procedure in local anesthesia or probably minimal anesthesia as compared to RFA. RFA causes a lot of pain post procedure. So that's the only difference.
So Randita, what is your practice and regarding the ablative procedure, especially into the bone tumors and mostly into the chondroblastomas?
Yeah, for the chondroblastomas, we are doing cryo nowadays, and even when we have done, and there is even after the post-op the post-procedure MRI, if it shows some peripheral enhancement or nodular enhancement, and we are worried about recurrence, the patient generally remains pain-free, and we till now have not had to do a repeat. Most of them have been less than 3 or 4 centimeters. I mean, less than 5 centimeters, at least all of them. So if it is amenable, the only concern is that sometimes there is a lot of cortical breach, and we are unlike the cryoablation of soft tissue tumors, the ice ball remains a very difficult to evaluate, especially when you're doing it in the bone window, practically speaking. So we have to be very, very careful. I don't know what Kunal's experience about this is.
Yeah, so I have one question that we have also brought up into our evidence-based guidelines, whether we have to ablate the lesion fully. So that is something. So can we do a partial ablation and look for the results, or we have to go out of the way, look like a do margination everywhere, and then deal with the complete ablation? So there are various literature which will favor either of the two. So what is your practice?
No, so we under ablate, because if you over ablate, there's a lot of concern about damage and weakening and breach. So for instance, I'm not sure what it will do to the bicipital groove or the tendon insertions if the bone is completely damaged by the cryoablation. So we under ablate and we do an immediate post-operative MR also. But right now we have not seen any sort of pain recurrence, even if the patient has a lot of post-op MR edema, which appears very, very disturbing when you look at it. But that is just post-procedure edema, which happens around the soft tissues also. But we have not seen pain recurrence after, although our experience again is very limited. It's just starting out. So,
Dr. Botsu, what is your center experience regarding the ablation in chondroblastomas?
Yeah, so in larger chondroblastomas, we have been doing cryo for over a year, and we tend to make sure that the whole of the lesion is included by using multiple needles. If you under ablate, we feel that then chances of recurrence is high, though we have about 18 months of experience. But we do about 2 cryos a week, 1 or 2 cryos, not for chondroblastomas. We only do it for fibromatosis. But in our experience, as Anindita said, it's very difficult to see the ice ball on bone. So you have to calculate and ensure that the needles will cover the lesion totally. But the results are good. And Peter Monk has done about 350 in Canada for the last 10 years. So I think it's a well-established technique. If there's a large lesion, like a large isolated metastasis or chondroblastoma, we tend to do cryo. For Mets, obviously, we do cryo and then we put cement in.
So, Anita, you have an extended use of cryo in other benign aggressive lesions like giant cell tumors?
No, actually, we are not doing so much in, especially metastasis, we are not doing, because actually cryo is expensive. So here, cryo with one needle only costs 1 lakh versus radiotherapy session, which may be delaying the pain relief, but still it is 10,000. So they will get 10 sittings of radiotherapy instead of 1 sitting of cryoablation. So financially, it is not viable for them. But in the patients who are affording and can do, it is really magical. The pain relief is immediate and just magical the way the pain goes.
Amit sir, the discussion is a bit too detailed for this forum. Like we are looking at probably basic. So and it's already 7. So do you want to continue with maybe one more case before we?
So I will just connect and then we will move forward for the quiz by Dr. Amit Chaudhary.
Yes, sir. Yeah.
So is a 51-year-old female presented with the chief complaints of pain in the left thigh since 2 months. There is a tenderness over proximal thigh. There is no neurological deficits, and these are the radiographs. So I think Anurima and Nikshita can take up these radiographs.
So I can see lytic lesion involving the left femur metaphysis and also the proximal diaphysis. And there is some endosteal scalloping and thinning of the cortex. I can also see some rings and arcs type of calcification. So probably a chondroid matrix within, and some periosteal elevation as well. So what was the age of the patient? 51-year-old female. So I think considering the age and the imaging findings, probably I would think of a aggressive neoplasm and likely a chondroid neoplasm like a chondrosarcoma.
Okay. Nikshita, Anandita and Dr. Borchu or Amit, you have any different opinion regarding that?
No, I agree. Chondrosarcoma.
I agree.
Okay. So Pratik, if it is a chondrosarcoma on imaging, what is the next level of investigation you will ask for?
Sir, we'll stick to the basics, as in a radiograph and then MRI and then a biopsy, and prove that it is chondrosarcoma, and then plan our surgical management after the staging of the procedure. So that doesn't change irrespective of what the diagnosis is. So we'll just, as we have shown, the next step would be an MRI, and then probably after that confirm with a biopsy. And if it comes out to be chondrosarcoma, get a CT chest, stage the patient, and then we can plan our surgical intervention.
Fine. So Nivedita or Anurima and Nikshita, are you happy with the imaging and you are sticking with the same diagnosis that you have given on the radiograph?
Yes, I think I would like to stick to the diagnosis which I already made, because it's very bright on T2. Sometimes contrast also helps, because if we see that peripheral nodular pattern of contrast enhancement, that also helps. Yes, so I think this is pretty classical.
Size. And the size and associated edema and everything fits into chondrosarcoma.
So I think we have to involve Poonam because he is here, and Poonam, so what is your opinion? So everybody is very confident regarding the chondrosarcoma. I haven't asked them the grade probably, but they are so confident they can grade also. So what do you think, Anurima, what is the grade of the chondrosarcoma based on imaging?
So I think definitely it's a high grade. I think grade 3.
And Dr. Borchu, what do you think between 1 and 3?
It's very difficult because we can't see extraosseous component. So it will be either grade 1 or grade 2.
Poonam, can you enumerate actually what you are looking on the PET slide?
Yeah, so here it's a very cellular lesion, as you can all see, and there are very closely packed chondrocytes, and there is some nuclear atypia seen in the form of binucleation, some enlarged nuclei. Honestly, I can't appreciate mitotic activity on this figure much, but the things we would look out for is the degree of cellularity and nuclear atypia, and the presence of mitosis. And if there is any area which is looking much more higher grade than these, this is definitely a chondrocytic lesion. And on this morphology, I would call it a grade 2 on histology. If it was little more cellular with lot of mitotic activity, then it would be pushed towards grade 3. But this picture is definitely of a grade 2 chondrosarcoma for sure. There could be other higher areas in different fields, but yeah, there's a lot of atypia here now that it's focusing. It is at least grade 2, and I would not be surprised if there are any other areas with grade 3 morphology also, because it is looking very busy, very very cellular, and nuclear atypia is there. Yeah.
Okay. So I think if you want, I can just share 2 minutes on this radiograph, because 9-year-old. What is Anurima? What is your thought process? I just want a diagnosis, actually, nothing else. Description part we can do later. It's a
9-year-old.
Yeah, benign or benign aggressive or aggressive.
So no swelling, fever.
So I can, chief complaints are pain since 2 months. No swelling, no fever, no history of trauma, nothing is there. Nikshita, Anurima, Anandita, Dr. Borchu.
I would think of an LCH.
Okay.
As one of the differentials.
Anandita, you have some
So,
different
yeah, so there is a metadiaphyseal lytic lesion, and there is obviously it is has a wide zone of transition, and there is absolute cortical breach. There is no transphyseal extension that we can appreciate, but posteriorly the cortex is completely destroyed. And
so what is your opinion? Any specific diagnosis, or you want to just label it as a benign aggressive or aggressive lesion?
No, this would still be an aggressive lesion, and I would first of all like to keep the possibility of it still being a variety of osteosarcoma.
Okay, so this is the MR picture that we are having. So whether you want to stick with the same diagnosis, or you want to change your diagnosis, or you want to give some additional differential diagnosis.
There is nothing as such. We can't see any soft tissue really still now. But again, we don't see a typical, the no fluid level as such. But it's some Ayurvedic treatment anyway, so we'll change the management. But again, it still remains aggressive. And here there's been a lot of remodeling, so this has become sclerotic lytic now. This is after just Ayurvedic treatment, or?
Yeah, this is after Ayurvedic treatment.
Oh, so that is a bit unusual, because then this has changed morphology and become completely sclerotic without any proper treatment. So again, then we have to revert back to the possibility. Are we looking at some, as Dr. Anurima again said, it could still be LCH, and the periosteal.
I think we need a biopsy, and probably we have to involve Poonam from this point. So Poonam, what is your opinion?
Let me just. There's some vacuolated cells. I'm not sure if I'm looking at macrophages, but also there's necrosis. So there is definitely some necrosis in this slide, and there are some vacuolated cells. So do they represent macrophages? Any other image do you have? I'm not seeing a lot of any nuclear atypia as such. Okay, here again it looks a bit. Seems to be like an inflammatory component, but a lot of macrophage-like cells in between.
I think there is an opinion from the radiologist. It could be LCH, it could be osteogenic sarcoma.
Yeah.
So
see, actually,
and there is no history or something like that. It's just in pain. There is no obvious swelling the patient is having.
I'm not able to really appreciate nuclear features like grooving or all. I'm trying to zoom in, but not getting the nuclear features very clearly. So there seem to be a lot of pale looking cells in between, which could be histiocytic and surrounding lymphocytes. I'm not seeing hyperchromatic nuclei or really obvious malignant features. So I still think there are a lot of these histiocyte kind of cells in between, but I would like to see it under a microscope. Okay, yeah, this is a better picture. How are you able to zoom it properly? I'm not able to do that. Okay,
no, I'm zooming.
So here, okay, so now I feel I would actually think more of a histiocyte kind of a lesion with a lot of inflammatory cells. I'm not seeing obvious nuclear atypia. This looks like there are some cells with some pale nuclei. A histiocytic lesion would definitely be LCH. Could be a good finding, though eosinophils I'm not seeing many. I would definitely want to do some IHC markers on this and see whether it fits into LCH. It is showing inflammatory background. I can't see osteoid, and I see a lot of these macrophages. So I would definitely want to rule out an inflammatory lesion or LCH.
So Dr. Borchu, would you like to intervene in an MDT There is a lot of discussion is going around whether it could be LCH or it could be osteogenic sarcoma.
Yeah, I mean, the problem is there is no soft tissue component, there is no extra osseous. I also thought initially it could be osteo on the first, but on the subsequent radiograph, because there is consolidation and this thing, so I think it could still be LCH rather than osteo.
Pratik, if there is a confusion both on the radiology side and the pathology side, what you will do next actually in these scenarios? Or Pratik has gone out, he don't want to discuss. So I think
no, but I think here we need a in IHC. Like we would want to do immunohistochemistry for confirmation. So the pathology report would be incomplete without doing immunohistochemistry markers. So that would be the next step to get a definite diagnosis.
So I think that this has been done. So these are the markers. I think it's mostly positive for LC and CD20, while it was negative for Desmin and NKX, MIG2 and ZB2. So probably, I think now you can able to correlate all those things.
Yeah.
Okay.
Yeah. So yeah, immunohistochemistry does have its role in these kind of cases. So I think that nicely sums up the case. Yeah.
So I think thank you so much all the panelists for their time on this Saturday evening. I think we have overtook some time, but I think there is a very interesting session. It is the quiz. The unfortunate part is that the consultant can't participate. It is only for the delegates that are here. And I think over to Dr. Porchu, Dr. Pratik and Dr. Amit Chaudhary to move ahead the session. Thank you so much.
Thank you, Amit sir, for that amazing discussion and amazing panel discussion. And thank you, Dr. Porchu. Sir, with your permission, if you say we go ahead with the quiz.
Yeah, carry on. Okay.
Yeah. Thank you. So this is a quiz which is for the delegates. Consultants can participate only through Zoom. They do not need to participate through the app because the prize money is only for the delegates. So first, the consultants just go through the questions as I read it, but the delegates will need to open this Kahoot app. You need a separate, you need to open it separately on your mobile. And once you do that, we'll have a demo session so that you get to know get the hang of how to play this. And then we'll have the actual quiz. So if the delegates can download the Kahoot app through the Play Store or the Apple Play Store, and then we can proceed with the demo quiz, and then we'll start with the actual quiz. So once you have downloaded the app, you will see you'll have to log in with your name and the city name. Because of the character limits, what we would advise usually is use your first name, the initial of your last name, and the city name. And once you've logged in, then the Kahoot app asks for a game pin, which will be shared by us on this Zoom meeting. And then we can play the Kahoot app and the quiz on the Kahoot app. So if everyone is ready, Amit sir, if you're ready, if we can just go through the demo questions first. Let's see how many people can join in, and then we'll start the actual quiz. So this is just a fun element that we are trying to see whether it works. And the August session had a good response from the students and even the consultants. So that's why we had to then start giving out this warning that consultants, please, let the students enjoy and have a fun time. So now Amit sir is sharing his screen and we'll have first the demo quiz. So if you can share the game pin of the demo quiz, so that we can just go through how the quiz is played, and then we can start with the actual quiz. So if the delegates have downloaded the Kahoot app, this is the game pin that you have to enter: 3698701. This is for the demo quiz, and we can then see the players who join in. for this demo quiz. So we'll wait for you. Let's have some enthusiastic participation. Yes, the participants have started. That's good. So we have around 80 participants on the Zoom meeting now. So let's wait till we reach 40 or 50 participants on this demo quiz before we go ahead and start the quiz. That's good. 23, 24. Yes. Join in. We are waiting for you. We are already overshoot our time. So we'll just wait for a couple of more minutes before we start the demo quiz. That's good. So that's a good number. 31 people have joined into the demo quiz. I think Amit sir, we'll start with the demo quiz, and for the main quiz, we'll then hopefully have more people joining in.
Sure.
So people can just have a look at how this game is played. So coming up with the first demo quiz question: who is the Prime Minister of India? Is it option red, Amit Shah? Is it option blue, Draupadi Murmu? Is it option yellow, Narendra Modi? Or is it the green option, Rajnath Singh? So this is a demo question. This is just to show how the app and the quiz works. So the criteria for selecting the winner is you have to be correct and you have to be fast. So we can see that 30 people have already answered. You have 30 seconds to answer this. Last 3, 2, 1. The correct answer, as we all know, is yellow, Narendra Modi. And there are 2 people who got that wrong. So maybe they're hoping for a new Prime Minister, but you'll have to wait till 2024 for that. So let's have the next question, sir. Next demo question. Which of the following is the national capital of India? Is it option red, Mumbai? Is it option blue, Kolkata? Is it option yellow, New Delhi? Or is it the green option, Bangalore? National capital of India, Mumbai, Kolkata, New Delhi, Bangalore. You have got the last 15 seconds to answer that. And once we have all the delegates who have answered, we'll get the correct answer for this question. So I believe now the participants are getting a hang of it. Remember, you have to be correct and you have to be quick. The correct answer, as we know, is yellow, New Delhi. So that, I think, concludes the quiz, the demo quiz. The main quiz is starting, so please stay around. So Praful from Nepal, first runner-up, Annar from Chennai, first runner-up, and the winner of the demo quiz is Alok from Kathmandu. But Alok, there's no prize for the demo quiz, so hopefully you'll participate in the main quiz also. So Amit sir, if you're ready, we'll start with the main quiz.
Yeah, sure. I hope I'm audible.
Yes, sir. You're audible.
All right. So I'll start my screen share.
Yes. So delegates, remember, simple. The game pin will be shared of the main quiz. You have to enter that and join the quiz. We'll wait for 2 to 3 minutes for maximum participants to join. And then we'll start the quiz. The winner gets a prize money of 2,500. First runner-up gets 1,500. The second runner-up gets 500. So there is some incentive for you to participate. Hopefully you will join in. Yes. We will be sharing the game pin now. Amit sir will start the quiz and then we'll join.
So is my screen visible?
Yes, sir. Your screen is visible.
Okay, great.
So please note, this is for the main quiz. So now we are starting with the main quiz. And the game pin for the main quiz is being shared. You have to enter this and participate in this. So 4807906. That's the main quiz game pin. 4807906. We are waiting for the players to join in and we have already started getting entries. Very good. We need more enthusiastic participation. Come on. This will just have questions based on what you have learned in this session. And as we are repeatedly saying, you have to be correct and you have to be quick to get maximum points. 38 participants, and it has stopped at that. So we'll just wait for a minute or two to see if anyone else joins in. Please note, people, we need you to enter the first name, the first letter of your second name, and the city or the place from where you are, because it will be easier to announce the winners like that. Okay, we have got 40 participants. We'll wait for a minute. So this is the last part of this session, and hope you had a good time with that lectures by Dr. Amit Janu and Dr. Kuku, and with the panel discussion. 41, and it has stabilized at 41. So I think, Amit sir, you can start with the quiz.
Sure.
So get ready. This is for the main quiz. 3, 2, 1. We are starting with the main quiz, and the first question of the main quiz is: identify the problematic bone in the radiograph. Is it red, femur? Is it blue, tibia? Is it yellow, fibula? Or is it green, none? There is a radiograph which is shared, and you have to identify the problematic bone. 10 more seconds to go. Amit sir, if you can just have that background music to add to the excitement, that would help.
Yeah, I hope that's audible.
Yes, yes, yes. And the correct answer is blue tibia. Amit sir, if you can just explain the radiograph.
Sure. So this is a frontal radiograph of an immature skeleton demonstrating a well-defined lytic lesion in the proximal tibial epiphysis without with a narrow zone of transition, without any cortical breach or frank extraosseous soft tissue. So this is a classic feature for a chondroblastoma.
That's great. That's great. So let's go to the next question. I can see around 13 people have answered that correctly. So the scoreboard at the end of that, that's good. We have got Renuka at the top. Let's see if she's able to maintain the momentum. Now the second question: what would be the next step after you see this radiograph? It's a radiograph of a femur with hip, with a lesion in the diaphysis. Will you go for red, MRI, blue, biopsy, yellow, amputation, or green, observe? Come on, people, you have got 10 more seconds. I think you'll have to increase the volume. People are not getting more enthusiastic, I think. And we have got a good positive response. Red, MRI, correct answer. 32 people have answered that. Very good. Sir, if you can explain the logic.
Sure. So again, here we have a frontal radiograph as well as lateral radiograph of the left hip joint as well as proximal femur. And what one can appreciate is that there is a permeative destruction seen involving the mid diaphysis of the femur, which is associated with focal areas of cortical breach and permeation, as well as extraosseous soft tissue. So this is suggestive of a aggressive lesion, likely differentials being an Ewing sarcoma and osteomyelitis.
Thank you, sir. Let's move on to the next question. Let's skip the scoreboard. Let's keep the excitement building. So now the third question. The following imaging is suggestive of: you've got an MRI of an axial scan and a sagittal scan. Is it red, myeloma? Is it blue, metastasis? Is it yellow, Ewing's? Or is it green, osteomyelitis? There is an image which has been shared, which is showing some soft tissue collection. What would, or is it a mass? What would you call that? Will you call it myeloma, metastasis, Ewing's, or osteomyelitis? Last 3 seconds to go. And the correct answer is green, osteomyelitis. Amit sir, over to you.
All right. So this is the axial T2 weighted MR image, which is being highlighted by the magnifying glass or my cursor, and that is the sagittal T1 post contrast fat chat image. And what we can appreciate on the axial T2 is that there is an area of altered marrow signal involving the mid diaphysis of the femur. This is also associated with altered signal in the cortex, breach in the cortex, and extension of the intraosseous abscess through a cloaca. Okay, so this is suggestive of osteomyelitis. In addition, one can appreciate that there is a sinus extending all the way from this cortical breach to the surface of the skin, which is suggestive of a discharging sinus. Another feature which can be also appreciated clinically in a patient with osteomyelitis. And that's a coronal T1 post-contrast fat sat demonstrating the marrow abnormality, cortical breach, the cloaca, with extension of the intraosseous abscess into the extraosseous soft tissues.
Thank you, sir, for that. So the observant delegates might have noticed the previous radiograph was of this MRI. Let's go on to the next question, sir. The fourth question of the September session quiz. We will have the MRI sequence which helps in knowing the intramedullary extent of a disease. Is it red, axial T1? Is it blue, axial T2? Is it yellow, coronal T1? Or is it green, sagittal T2? We need the background music to add to the suspense. There are 16 seconds to go. It's a straightforward, it was discussed in the panel discussion as well, the MRI sequence which helps in knowing the intramedullary extent of the disease. Last 5 seconds to go. Red, blue, yellow, green, and the correct answer is yellow, coronal T1. Sir, if you can explain the logic behind that.
So for looking at marrow abnormality, it is the T1 weighted sequence and a stir sequence which best depicts the marrow abnormalities. And whenever we are doing imaging for looking at extent of any skeletal neoplasm, we also need to delineate the craniocaudal extent of this abnormality, which can be best seen on coronal T1 and or coronal stir images. Hence the answer here is coronal T1.
Yes, thank you for that. Let's, I think, move on to the fifth question. Renuka is still holding the top position, I guess. Very well done. So now we have a 14-year-old male with pain around the right hip. Identify the lesion and classify. So there's a radiograph which is shared. You can see a lesion there. Is it red, benign? Is it blue, benign, aggressive? Is it yellow, malignant? Or is it green, no abnormality? Is it that? So last 10 seconds to go. Is it a benign lesion, a benign aggressive lesion, a malignant lesion, or is it no abnormality and the pain is somewhere else? So time's up and the answer is benign aggressive. Sir, if you can explain that.
Okay, so again, we have a frontal radiograph of the pelvis as well as proximal femurs bilaterally. And what one can appreciate on this radiograph is that there is a focal lytic area which is cortically based involving the proximal femoral shaft, medial aspect, just inferior to the lesser trochanter. And this is also associated with some cortical thickening. So these findings are consistent with, or rather suggestive of, an osteoid osteoma, which is a benign aggressive lesion.
Okay, thank you for that. Hope that solves the query here. Let's have a look at the scoreboard after 5 questions at the halfway mark. Oh, Renuka has been overtaken by PK. Oh, we have got a celebrity delegate among us. PK is now leading with 4101. Come on, there are still 5 questions. We can still have a change in this. Let's see. Let's go on to the 6th question. Classify the abnormality in the following image. The image is showing a yellow malignant lesion, or is it a green touch me not lesion? You can see a lesion in the radiograph which is shared. It is there on the distal femur. It is there in the proximal tibia. It is there in AP. It is there in lateral view. Last 5 seconds. Is it benign, benign aggressive, malignant, or touch me not? And the correct answer is touch me not. Sir, if you can explain that.
Sure. So again, a frontal and lateral radiograph of the left knee joint, wherein one can appreciate that there is an abnormality in the distal femoral and a proximal tibial metaphysis predominantly, which is having sclerotic margins and some internal sclerotic areas. and this is suggestive of a bone infarct. And bone infarcts usually do not require any active management. Hence, this is a touch me not lesion.
Thank you. A bony infarct that was, which is, as sir mentioned, touch me not. Okay, let's go on to the 7th question. Come on, last 4 questions left. Let's see. Classify the abnormality. So again, an image question. Again, you see a distal femur with tibia lytic lesion. Is it red, benign? Is it blue, benign, aggressive? Is it malignant, or is it green, no abnormality? So you'll have to keep that maximized. Oh, it is blue, benign, aggressive.
So
Sir,
that is the correct answer. Why so? So again, we have a frontal radiograph as well as lateral radiograph of the right knee joint, wherein one can appreciate that there is an eccentric, well delineated lytic lesion with a narrow zone of transition, which is nearly abutting the articular surface without any obvious extraosseous soft tissue or pathological fracture or cortical breach. So this is suggestive of a giant cell tumor, which is a benign aggressive lesion.
Thank you for that. So yes, so before moving on to the next question, if you can just adjust the volume, because the last 3 questions are coming up, and we need that background because I think it's going into mute.
Okay, so I muted on purpose so that you are audible, but then okay, I'll
Yes, sir,
make
yes,
it
sir,
maximum.
let it be for the last 3 questions. Okay,
All right.
let's go on.
Okay, sure.
So now we have the 8th question. Identify the matrix in this diagram. You can see a proximal humerus with a lesion. Is it red, osseous? Is it blue, chondroid? Is it yellow? There's no matrix. Or is it green, infarct, which was discussed? You can see a proximal humerus. You can see the lesion. Identify the matrix. Last 10 seconds to go. And the correct answer is blue, chondroid.
So we have a frontal radiograph of the left shoulder joint here, wherein we can appreciate that there is this area involving the proximal humerus, which is hyperdense or quite dense appearing on the radiograph, which is showing stippled calcification or rings and arcs of calcification, which is considered to be a characteristic chondroid matrix. Hence, chondroid matrix is the correct response here.
Thank you for that. And sir, let's have a look at the scoreboard.
Okay, I skipped it to next
No
question.
problem. Now after this, we'll have a look. Identify the matrix. You can see a lesion, distal femur. Is it red, osseous? Is it blue, chondroid? Is it yellow, no matrix? Or is it in fact green and infarct? Distal femur lesion which is seen. What is the matrix that you can see? Last 10 seconds to go. Come on. Oh, fantastic response. Everyone has got that correct. It's an osseous matrix.
Yeah, that's a brilliant response from all the participants. So again, frontal radiograph of the frontal and lateral radiographs of the distal femur and knee joint, wherein we can appreciate that there is a dense lesion involving the distal meta, epi, and diaphysis of the femur, which is associated with sunburst periosteal reaction. So those speculations there. And also this is leading to extraosseous soft tissue, which is leading to displacement of fat planes around the distal femur there. So this is highly suggestive of, or in fact characteristic of, an osteosarcoma. Hence, osseous matrix is the correct response here.
Fantastic. We have got an all correct answer. Let's see the scoreboard for this.
Sure.
So now we have got PK who is leading still. Come on. This is the last chance for people to overtake him. We have got the last question coming up and you still have got a chance. So a 25-year-old female with pain along the right thigh. Imaging is suggestive of red, osteomyelitis, blue, fibrous dysplasia, yellow, metastasis, or green, metabolic disease. 26 people have already answered. Last 15 seconds to go. A lesion in the proximal femur. Is it osteomyelitis, fibrous dysplasia, metastasis, or metabolic disease? Why? Oh, fantastic. 32 people have got that correct. Fibrous dysplasia. Sir, if you
So
can
that
just-
is, so majority have got this right, which is indeed the correct response. Again, we can see that this is the frontal and lateral radiograph of the right hip joint as well as proximal femur. And we can see that there is again a well delineated expansile lytic lesion, which is present in the proximal femur, which is associated with a ground glass matrix without any breach in the cortex and or extraosseous soft tissue. So this finding associated with, this ground glass matrix, which is considered to be a buzzword for this abnormality, is considered to be characteristic of a fibrous dysplasia, which is the correct response.
Fantastic. So now I think that was the last question of this quiz. So now we will have to see who are the winners. The podium is being announced. Second runner-up with 8 out of 10 correct is Anne B. Spacey. Then SPS Varanasi has got the first runner-up, and PK has overtaken everyone and has scored 10 out of 10. Fantastic. I hope that's not a consultant who has joined in and got a 10 out of 10.
So congratulations, PK.
Congratulations, PK. If you are online, if you can just switch on your video and we can have a word with you.
Okay, sure.
Is PK around? Or has he left the planet?
Hello.
So PK,
Hi,
can you
hi.
turn on your video?
So, congratulations. I can see your name as Pankudi.
Yeah, thank you.
Congratulations. And how are you feeling winning this musculoskeletal radiology quiz?
No, I'm just a bit surprised.
Hopefully you like the session and the quiz, and we hope to see you in further sessions also. This is going to be a monthly affair and we'll cover various topics. So please share it among your friends and colleagues, and we hope to see more people join in.
Okay, sure. Thank you.
Thank you. Sir, I think that's it for the quiz. Amit Janu sir and Professor Rajesh Bochu, last words for this session.
Yeah, I would like to thank all the people who have helped to make this session a success, all the people who have participated in the quiz, the panelists, and more importantly, the organizers and the audience. I think sarcoma, with this type of session, it's important that people identify the key features and help to identify the tumor early. Have a good day. Thank you.
Thank you for joining in, sir.
Thank you.
Thank you.
Thank you, Prateek. You have taken an extreme laborious effort, even on this day when there is a parallel session going on, and waiting instead of US Club, sitting in some room and conducting the session. I think Dr.
I'm also in
Bochu have taken
TMS
out
with
the
you
time.
only.
Yeah. So thank you so much, everyone, for participating in a large number. And I think the enthusiasm among the residents and the junior people is extremely high. And we have seen that it is a very well conducted quiz, and PK has won the final rounds. So I think have a great evening. Bye-bye. Good night.
Thank you, sir. Thank you all for your participation. It was an enthusiastic response, and we hope to see such an enthusiastic response in further sessions as well. Thank you, Amit sir, for those wonderful questions. And hope you also spread the word in your groups for further sessions in oncology. Thank you all.
Thank you.
Thanks a lot.
Bye.
Yeah.
Bye. Have a fantastic weekend all.
Thank you. Bye.
Nikita, if you're around, or Hemant.
Yes, sir. Yes, sir. I mean.
Yeah. I think we covered everything. So, and we have got
Yes,
everything.
sir.
So
And 40
thank you for your help, and we'll catch up soon for the next planning of the next session.
Sure.
Thank you. Thanks a lot. Thank you, Ashish, also for taking the
Thank you,
effort
sir.
to join.
Yeah. No, thank you, sir.
I think Nikita has already left. She has gone to enjoy her Saturday. So let us also leave.
Yes, sir. It went off smoothly.
Yes. Thank you.
Thank you, sir.